Assessment and planning, data from the NAP4 project. I thought today would probably be full of information and overrunning, and I've therefore prepared an 8-minute talk. An elderly patient presented for elective VATS procedure. No airway assessment was undertaken, and my italics, consequently, no airway management problem was anticipated. So the patient off to sleep, and they try to intubate. They note that there's limited neck extension and prominent teeth. They fail to intubate. They abandon the procedure. They put in a supraglottic device. They wake the patient up. They take the supraglottic device out because the patient seems to be awake, but in fact the patient doesn't seem to be very well. Really, the oxygen saturation stay low. They in fact put a nasopharyngeal airway in, but there's lots of bleeding. And after 10 minutes, the surgical registrar, cardiothoracic registrar who's been standing there, puts in a percutaneous tracheostomy, and they send the patient to ITU. We know that it's our job as professional people with the high-level instruction that we must assess the patient before anaesthesia and devise an appropriate plan of anaesthetic management. And if we're not to do that, we are acting outside anything that might reasonably describe an anaesthetist. In the NAP4 project, there are 133 anaesthesia forms, and it is likely that in 25% of forms had no written information about the airway on it, and it is possible that a considerable number of those had not had an airway assessment either. It's difficult to know, but certainly it's not recorded. Ian Calder has come out in his excellent, modest way to tell us that, in his view, as a minimum, as an airway assessment, clearly there's history and examination, but as a bedside interactive test with the patient, opening the mouth, mandibular protrusion, and looking at the teeth to see if they're awkwardly placed is a routine. And as Ian says, which is quite true, it would be unconscionable to find that a patient had an interdental distance of only 1 centimetre after induction. Now, there are 133 anaesthesia reports, and difficulty with airway management, which is a specific field, yes or no. Did you predict difficulty? Anticipated 66, not anticipated 67, i.e. half and half. Anticipated problems were the majority, or the largest number, was difficult direct laryngoscopy and intubation, and I think that fits with our clinical practice. That is what we predict most commonly. We may not be correct, but that is our prediction. We also had fields for ticking difficult face mask ventilation, difficult direct tracheal access, difficult supraglottic device insertion, and difficult pre-oxygenation. And you can see the prevalence of those. We know that if the problem is anticipated, it allows us to plan, and it allows us, of course, to do a large number of things like get help, get extra equipment, postpone things, even cancel surgery, do it under a regional block. But whatever we're going to do, if we're going to persist with general anaesthesia, we're going to adopt a strategy that is likely to deal with the predicted problems. Here is a non-obese adult with trismus who's going to have an infected mandibular plate removed during daylight hours. The anaesthetist assessed the airway, and he or she felt that there was difficult face mask ventilation, difficult direct laryngoscopy, difficult supraglottic device insertion, and difficult direct tracheal access. This isn't quite the full house. There are only 2 patients who had difficult pre-oxygenation as well. So patient cooperation was not a problem in this patient. However, let's bang on with general anaesthesia and paralysis. And after unsuccessful attempts, including fibre optic intubation once asleep, difficult ventilation, you can see saturation is 25%. The airway was eventually rescued by a difficult surgical tracheostomy. We know really that difficult direct laryngoscopy and difficult face mask ventilation are indications for securing the airway awake. Here's an adult patient with ankylosing spondylitis. During daylight hours for intestinal obstruction, the trainees found the patient. The trainee goes to the consultant saying, "Can you help me?" The consultant thinks that it's going to be a difficult direct laryngoscopy with a risk of aspiration. Therefore, the patient's managed by a rapid sequence induction. When intubation is not possible at rapid sequence induction and the succinylcholine is wearing off, they give rocuronium so that they can continue. And they then try to intubate through the supraglottic device with a flexible fibroscope. And when this has failed, they're going to give more rocuronium and carry out the whole thing on a supraglottic device. Clearly, we know that difficult direct laryngoscopy and a risk of aspiration is an indication to secure the airway awake. We also know that if we're doing a failed rapid sequence, in a non-emergency and we get into trouble and can't intubate, we should wake the patient up and think again and do something else. I think NAP4 has identified unanticipated clinical situations which might define the core group that an anaesthetist should think about. How am I going to manage failed direct laryngoscopy, failed ventilation, failed intubation at rapid sequence? They happen to be covered by Difficult Airway Society guidelines, which I think at least need to be looked at. Locally, you may well think something else should be done. Aspiration with a supraglottic device, loss of airway with a supraglottic device, and extubation recovery problems. And I found myself in the last 3 years, virtually every time I start a case or rapid sequence, I tell you specifically to the ODA, if I fail to intubate, I'm going to do X. Commonly, it's wake the patient up. If I fail to intubate here at direct laryngoscopy, I'm going to put in a laryngeal mask, and I want you then to go and get the fibroscope or whatever it is. A strategy is a combination of plans to deal with whatever problem you've identified. And in our view, and Jan Shaw and I wrote the chapter on assessment planning, the more commonly the adopted strategy is a nationally or locally agreed one, everybody knows what it is, the greater likelihood that it will be executed successfully by the team. Awake fibre optic intubation was sometimes not selected, even though it would seem ideal. Here's a 115 kilo patient scheduled for thyroidectomy. We know their neck is going to be enormous. They've got sleep apnea, limited cervical spine mobility and tracheal deviation. However, we're going to set off with general anaesthesia using remifentanil, propofol and sevoflurane. Now, it's not possible to see the vocal cords at all with an attempt at direct laryngoscopy. And after positioning the patient again to try and get a better view, it's now not possible to ventilate them either, and they of course they're rescued by a very difficult difficult tracheostomy. Saturations are less than 60% for 20 minutes. Now, if an awake intubation would be best, but an individual anaesthetist can't perform one, should the anaesthetic department have collective responsibility to provide one? And in my view, the answer is yes. What is an inhalational induction? Is a combination of remifentanil, propofol and a volatile agent, an inhalational induction. I admit to being a fat old man, but it isn't as far as I can see. What happens when the airway fails? Are you going to give a muscle relaxant? Thankfully, Ian Calder and Steve Yentis over the last few years have permitted us to think of giving relaxants, where some years ago we would not have been allowed to think of giving it. Ian has never said that you must give a muscle relaxant. He is trying to give you permission to give a muscle relaxant, and certainly you must think that it's glottic reflexes that have destabilized the airway. And it's quite clear that in a number of patients, the patient was neither awake nor asleep and could not be managed. The anaesthetic room is a historical structure which is soundproof, and it is soundproof so that when you're doing an inhalational induction on a child, the sound of a porter breaking wind in the corridor will not destabilize you at a critical stage. Often they have signs telling you that you cannot come in, and the only thing the theatre staff know about the anaesthetic room is that they must never enter it. So clearly it is not a position. And interestingly, in my 25 years in head and neck anaesthesia, the surgeon has never requested to do a tracheostomy in the anaesthetic room because it is simply not suitable. Aspiration risk, Tim's on that. Good news. Here is the model we used for airway management. ASA inspired it in the early 90s. We're going to assess the airway, we're going to prepare for difficulty, we're going to have strategy at intubation, strategy at extubation and follow-up. Clearly they were obsessed in the 90s with intubation. It's just strategy at the start of anaesthesia care. In this model, you can predict that there are going to be adverse events if you don't do an airway evaluation. If you do an evaluation, but it's not very good at picking up difficulty, and we know that that is a problem. If you pick up some problems, but you don't, if you haven't devised a strategy at all, or if you devise a strategy which is inappropriate to the problems that you've predicted, you're going to go wrong at times. It may be that the strategy, which is considered best practice by the whole anaesthetic community, is adopted, but we know that everything fails. And here we are looking at the result of 3 million anaesthetics. Of course, we are going to see cases which may be best practice, but everything fails at some time. It may be that there is a strategy, it's quite reasonable, but the team can't complete it because of problems, they don't have the skill, the equipment, the experience, or whatever. Or it may be, particularly in urgent cases, that the resources can't be assembled in time. So, in fact, you can't complete it because you actually don't have the resources that you need. Recommendations. All patients should have an airway assessment. The risk of aspiration should be assessed and the adopted strategy adjusted appropriately. Awake intubation should be used when indicated. We should have explicit policies for failed or difficult intubation, and we should use those strategies in our daily practice. Thank you very much, Ian.